And welcome, folks, to the Free Market Cash Patient Weekly Webinar. I'm your host, Charles Frohman, and my co-host, Jeff Cantor, is just driving back from a business trip, so he will be rejoining us next week. We are sponsored by the Freedom Hub, and it is a place for liberty activists and economic disruptors to join together. And I'll show you our website at YouTube, where you can see all our past guests. This is by popularity, and there's Dr. Arshad there, and Dr. Labo, and Dr. Khalsa, and Christina Demores. If you scroll down on your own at the Free Market Cash Patients channel, you'll see all our past webinars, so I encourage you to check that out. And we do have videos at Brighteon and BitChute as well, because we're not big fans of CensorTube, as we call it, YouTube. We are sponsored by yourfreedomhub.com, and our big promotion is our health plan, which was featured in Forbes, because we create cash patients using sharing and health savings accounts, as Goodman featured our company. And it's pretty popular, and we were embedded in this app that supports cash appointments. It also got an award at a recent benefits conference, and is a place where you can control your medical records and access telemedicine, which is so popular nowadays. So just contact me if you want to cut your costs in half and help the cash patient revolution. And speaking of the cash patient revolution, our guest tonight, Twila Brase, is a pioneer in that field. She has her own network of doctors at the WEDGE. These doctors only take cash. And as more and more people recognize the benefits of shopping on price and quality, they will soon join this market because it offers so many more choices and pleasure. It's a great future for healthcare. Twila also is a hero in privacy. Her Citizens Council for Health Freedom is a growing movement out of Minnesota and nationwide. And do check out her book, Big Brother in the Exam Room. And so without further ado, I will stop sharing. Twila, if you want to share your screen, and then folks, after she finishes presenting, just click the raise hand icon to make a comment or ask a question, and here we go.
So I take it my screen is showing well on your end?
Looks great.
Okay, that's good. Well, thank you everybody for coming for this presentation, and this is called Healthcare the Way It Should Be. I have run, well, I co-founded Citizens Council for Health Freedom. It's been about 25 years that I've been doing this work. I'm a registered nurse and an emergency room, pediatric emergency room nurse by training, but have been doing policy for 25 years. So it's our mission to protect healthcare choices, individualized patient care, and the right of individuals to medical privacy and genetic privacy. And let's see, whoop, I clicked the wrong thing. Okay, some of the key things that we do are trying to stop single payer, however that looks, whether that's Medicare, Medicare for all, the public option, Obamacare, the accountable care organizations, or even the health plans, which we look at as the corporate version of socialized medicine. After all, it was Senator Ted Kennedy, who is a proponent, or was a proponent of single payer, who put the HMO Act into place in 1973 and really began the empowerment of health plans across this country. Hillary Clinton wanted to do it in her bill, but was not successful. Then Medicare Advantage came, which is putting people into health plans through Medicare. And then the Obamacare, the Affordable Care Act, said that everybody had to have a health plan. and it got rid of regular insurance. So these, well, we look at stopping single payer and socialized medicine from all of these angles. Restoring patient and doctor freedom is key to having freedom, having choices, not having limits, and then of course protecting patient privacy, which is the foundation of freedom. We say he who holds the data makes the rules. And so if you do not and are not able to control your data, limit people from being able to analyze you or control your doctor according to quality measurements that then are hinged on reimbursements, then you do not have freedom in the exam room with your doctor. Some of the patient privacy issues are HIPAA, the unique patient identifier, electronic health records, and baby DNA, which is the storage of newborn DNA by states. So I like to just let people know how third parties got into control, because they shouldn't be in that kind of control. After all, you don't have control over what kind of home you buy or what kind of home insurance you have. You don't have that in the other parts of your life, but we have it in healthcare. And how did that happen? And so this is just a timeline, a simple timeline. It doesn't include all the bills, all the legislation. I do have a more complex timeline in my book, Big Brother in the Exam Room, because the whole reason that they're taking over control through the electronic health record is to try to have all this third-party control through the data. So 1943, the employers were allowed to offer health insurance to employees tax-free, essentially as a tax deduction for the business. 1954, that was codified into federal law. So it was the War Board who did it in 1942 during World War II, but Congress did it in 1954. In 1965, then Medicare and Medicaid were enacted by Congress. As I talked about the HMO Act of 1973, it was Nixon. President Nixon was a real fan of HMOs, and Ted Kennedy who did this together. The Clinton Health Security Act was introduced, really giving, the whole plan here was that we would all have an HMO, we'd all be in regional alliances across the country, and we'd all pick from an HMO, and that would be the only choice. Then 2009, the American Recovery and Reinvestment Act, or ARA, otherwise known as the Economic Stimulus Bill, and then in 2010, the Patient Protection and Affordable Care Act, otherwise known as the ACA. Some people call it Obamacare. I tend to not. I tend to call the coverage product that comes out of the Affordable Care Act Obamacare, and just leave the ACA as the way that I refer to it, because it is, after all, a 2,700-page bill with so many other things other than that coverage program in it. Okay, next slide. So, you know, healthcare the way it should be. So how should it be? Well, we believe it should be personalized treatment, individualized care. The patient and doctor should be able to have a relationship if they would like one, and one where the doctor actually knows the patient and you're just not going through on a conveyor belt. There should be patient consent and privacy rights, choice of care and coverage, first party payment rather than third party payment, so that you can have insurance right in the back, but you're the one who pays the bills, and then the insurance should pay you. So real pay the patient insurance, and then the affordable care. We should have affordable care and coverage. There's no reason that we can't have that. Both of our medical care and our coverage for care cannot be affordable. It's just because there's so much third-party involvement that we are at the state that we are in. So an alternative system is what we're looking for. And so one of the things that we did was we wrote the Made in America Healthcare Act. And we actually did share that with the White House, and in September of 2019, we called it MAHA. We thought that might spark their interest, with MAGA being what the president's whole what motto is. And then there are 10 principles to it. Restore indemnity, real health insurance that pays the patient. Number 2, take steps to end pre-existing conditions, problems. You know, the whole reason that we have pre-existing conditions is because we have insurance that stops at a certain age, or that stops after you leave a job. We don't have our own insurance. So give individuals or no one a federal tax deduction, so that the ownership will start going back to the individuals in the purchase and the payment, and it won't be tied to your job. So seniors should be free to buy private insurance, and they should be free to opt out of Medicare. We have secured an executive order from the president to make sure that you can still get your Social Security benefits if you choose to opt out of Medicare. It's not yet in place, so we are working to make that in place. Currently, and for the last 27 years, that has not been the case. If you choose not to have Medicare, you can't get your Social Security benefits. Not a law, not a rule. It's just something that the Clintons decided to do, and it's been followed ever since. So we're waiting to get this executive order actually in place, and well, it's in place, but to make it actually happen, to make it real. Okay, number 5, speed patient access to innovative drugs, lower prescription costs. The FDA really does make everything more expensive and so much more time consuming. Number 6, restore patient control, confidentiality, and consent, because after all, he who holds the data makes the rules, and therefore to get a freedom back into the system, they have to have control, confidentiality, and consent. Number 7, stop the physician exodus from the practice of medicine. I don't know how many of you realize this, but a study that was done in September 2016 found that a little bit more than 48% of physicians or maybe it was just 48% of physicians are making plans to leave the practice of medicine. So that would be basically half of our doctors in this country. And yet we have 10,000 baby boomers entering Medicare every day. We need to stop that exodus and the reasons for that exodus, which include the electronic health records, all the data collection, and the fact that they feel like data clerks these days, and then the fact that third-party payers tell them what they can and cannot do with patients, or tell them if they do it, they won't get paid. Okay, number 8, keep the mission of medicine alive. We have really put the business of healthcare in place of the mission of medicine. Another reason why doctors are leaving, because they are on a mission and have always been on a mission and only spend that many years of their life because they are on a mission to take care of patients. But now the business of healthcare sort of rules the day. Number 9, pay for care and not coverage in Medicaid. This is one of the biggest places where the health plans are making lots and lots of money because they get paid per member per month, no matter how many patients never ever see them, no matter how many enrollees never ever go into the doctor. And the Medicaid population is just sort of a cash cow for the health plans. If we actually just paid for the care of those who came in, we would have a better deal. And number 10, enable competition and discourage consolidation in order to bring the prices down and get the best care that you can have, because doctors and hospitals are working for you. They would not be working for the government or the health plans. Okay, so several successes. As I said, we got this opt-out. President Trump signed this executive order on October 3rd. It was for 6 months, which was March 31st, but of course, COVID-19 struck, and we know things move kind of slow in the bureaucracy anyway, so we were hopeful, but we weren't holding our breath. So we do know, because I've been in contact with them, that they are definitely still working on making this happen, but it has not happened yet. And when it happens, people will be able to opt out of Medicare and keep their Social Security benefits. This could include people who, the first ones will probably be those who are in health sharing organizations, which are cooperatives that share each other's medical expenses, like Samaritan Ministries or MediShare. And they, Samaritan Ministries in particular, does not require you to go into Medicare once you reach the age of 65. And so these folks could get their Social Security without having to go into Medicare. Today, they have to go into Medicare to get it. Okay, another success is the Minnesota Health Records Act. In Minnesota, we have the strongest state medical privacy law in the nation, and we have been having to rescue it from corporations and other big business players for about the last 5 years. And so far we have managed to protect it because we have had bipartisan support, and we have worked with members on both sides of the aisle to protect it. It says you have to have consent no matter what. There's only 3 small exceptions, plus the exceptions for certain public health reporting to state government. But we don't follow HIPAA in the state. We follow the Minnesota Health Records Act, which is much more protective of privacy. The electronic health record mandate was lifted in Minnesota. Minnesota had the only mandate for electronic health records. Everybody else has really been under the federal law, which says if a doctor does not use an electronic medical record that is designed for government purposes and approved by the government certified, that they will receive a reduced payment for every Medicare patient that they see. So it is a quasi mandate across the entire nation, including Minnesota, but at least in Minnesota, we got the actual mandate, the real mandate lifted. Then Baby DNA, we are the organization in the country that discovered this issue and have pursued it ever since that discovery in 2003. We have had 5 lawsuits. I can hear a phone ringing and I'm just gonna shut it off. Okay, we discovered this issue, and so 5 lawsuits, 1 in Minnesota, 2 in Texas, 1 in Indiana, and 1 currently taking place right now in Michigan through the federal courts, and they have had a win. We have had wins in Minnesota and in Texas. Only loss was in Indiana. But we are working to get a law at the federal level to mandate parent consent before the DNA of these children which is being stored by the state, can be used for research. And I guess I wasn't very clear, I realize, in starting this out, because most of you probably don't know what the baby DNA issue is. So just to be clear, parents have a child, and within 48 hours, the hospital pricks the heel of the child, drips it onto special filter paper, which is sent to the state government and for newborn screening, which is really the largest genetic testing program in the country, and it's conducted by the government. And back in the 90s, state health departments started looking at, they started keeping the results into a database permanently, and then they also started looking at those cards and realized that that was DNA of every child born in the nation, and many states started to keep it. So we discovered that in 2003 and have been working ever since to stop this, this warehousing of newborn DNA without parent consent, and the use of it without not only parent consent, but the consent of the child, who in many states, they are already adults and their DNA is still in storage. Okay. Another success, prescription monitoring program in Minnesota. We got the first ever transparency laws in the country, and we have created a, let's see, what do we call it? It is a, model legislation library. And so we are creating these pieces of legislation that anyone in any state, any legislator can take, any proponent of privacy and other patient protections can take this legislation and just incorporate it into their state law. So this is one of them, all the transparency for the prescription monitoring programs. Every state has one. Patients don't have any consent over it. Prescribers and pharmacies can have access to all the information in there. It's really about controlled substances, but it also includes Sudafed. And if you've just gotten 1 pill at the dentist's office for a procedure, you're in the database all without your consent. And there is this attempt across the nation to incorporate the prescription monitoring systems, these government systems, right into the electronic health records in every hospital and every clinic. So we're working on more transparency for that. Whoops. The Health and Human Services had a quality summit last year. I was a selected participant in that, sharing really how we think the whole quality measurement thing, all this data collection from your doctor's offices doesn't really mean quality. It's really just a way of getting doctors to comply with the way outsiders want the medicine to be practiced. And I was a pretty much of a lone voice on that, but pretty much we had an impact in what happened just because of speaking up. And then we stopped the funding for the unique patient identifier, which is a national patient ID that would connect all of your data together and likely end up with a no card, no care situation in the exam room. And so it would be a tracking number, and it's law, but they've never funded it. mostly because of Congressman Ron Paul, who stopped the funding for years. Now he's out of office, and we're working with his son, Senator Rand Paul, to stop the funding of the unique patient identifier. Okay, so here are some of our major initiatives. I've kind of talked about them, but this gives you a sense of maybe some of the typical pictures or logos and the URLs where you can find this. Over here we have itsmydna.org, which is all about baby DNA, the lawsuits, the retention schedules of every state. We've been keeping them, I think, since 2001. So you can see how long your state keeps the DNA of children in your state. There are also how to contact your health department, the Commissioner of Health, and to ask for your child's DNA to be deleted from their system or destroyed from their system. So that's all available at itsmydna.org. We have this e-newsletter that comes out every week, every Wednesday. We provide information, our latest press release, tweets. We're now sharing our COVID-19 videos and other information that we hope that people will find useful. And you just need to subscribe, and you can go right there to subscribe. Patient Toolbox is pretty new, and it's to help people deal with the coercion that they're finding increasingly in the exam room. The exam room should be a sanctuary, not a coercive place, but it really has become one. If you don't sign their forms, if you don't answer their questionnaires, if you don't do this, that, and the other thing. And so we actually have concrete examples of what you can do to help yourself in the exam room. We also have a list of all the credentials. So if somebody walks into the exam room and you don't know who they are and it says something at the end of their name, you can just look up our credentials list and you can see what they are and what kind of training that they have and whether they're a doctor or a nurse or something completely different. We have Join the Wedge over here, the Wedge of Health Freedom. This is our online directory of cash, check, or charge practices, which was referenced at the very beginning of this webinar. And then the whole campaign against HIPAA, because HIPAA is not a privacy law. It is considered a permissive data sharing rule. 2.2 million entities can have access to your data without your consent if those who hold it choose to share it. So we have this special card that you can take with you to the exam room or to the hospital, and for why you refuse to sign the HIPAA form. So those are some of the initiatives. Here is the piece about baby DNA. The many states storing the DNA after the newborn screening is done. Some are selling it. Texas was bartering it and selling it. The federal government actually had asked for DNA from 4 different states for a race-based or ethnicity-based military database, and 4 states provided that without the consent of parents. 5 parent lawsuits, as I said, and we are working to get a federal consent law. HIPAA stands for Health Insurance Portability and Accountability Act, and it's that's the law itself. And then there is a rule, and the rule came out in 2003, and that's what everybody abides by. But as I said, it is a permissive data sharing rule. 2.2 million entities get it, plus government. So whether that's local, state, or federal government. As somebody once told me, they have been under the illusion that HIPAA protects privacy, and they are now realizing that it does no such thing, and that's true. Now, healthcare operations, this term right here, is nearly 400 words long, and it is essentially a list of about 65 different business activities for which your data can be shared without your consent, unless you have a stronger state law, like we do here in Minnesota, where they have to get consent before they can share it for all of these different things, for analysis, for law, for legalities, for auditing, for all sorts of things. And then there's these 12 priority purposes, which are in the rule. Things like sharing it for law enforcement, public health, administrative hearings, organ donation, so that if you have a parent who's dying, for instance, and the hospital thinks that they're going to die, but they have good organs, they can call up an organ procurement organization who can then come to your door at the hospital and begin to ask you questions. Now, they do not have to ask you. The hospital does not have to ask you before calling this person to your hospital bed, which we would certainly like to change. So we want everybody to know that HIPAA is not what you think it is, and it is actually a permissive data sharing rule unless your state has a stronger state law, like the Minnesota law. And again, the Minnesota law is in the model legislation library that is on our website, cchfreedom.org. Okay, the WEDGE. So the Wedge of Health Freedom, here is a fairly current map of all the places where there are WEDGE clinics. So cash, check, or charge, and they have 8 principles that they need to follow, and one of them is true privacy. And as you can see here, we have 427 practices so far. I'll make sure that's actually what this says, practitioners. 409 clinics, and we are in 47 states. It's so interesting that the Dakotas, we're nowhere in the Dakotas, but we hope that that's coming. We don't necessarily, obviously there are other clinics around that are only cash, check, or charge, particularly the direct primary care clinics, but they aren't all on here because they don't know about the WEDGE, and some of them are so busy that they don't want to be in the WEDGE because they don't want anybody else to know about them. But these folks do, and their whole purpose is you, the patient. So you are the sole source or the sole reason for their practice, and you are treated like a customer, not like a burden and somebody who's taking too long and asking too many questions. Okay, some people want to know why we call it the WEDGE, and here you go. So today we have these direct primary clinics. We have some other fee-for-service clinics, which means they've got a list of services, and you know, whatever the services are, you know right there what the cost is, and you pay at the time of care. And so they exist, but for the most part, they're kind of invisible. And what we want to do with the WEDGE is not only let them be visible in this wedge here, but actually grow the number of clinics and practices. And as I told you, half the doctors are planning on leaving. So we would like them to leave into the WEDGE if they're, you know, if they don't really want to retire. You know, do something where it's just you and the patient, which is what they signed up for in the very beginning. And then in the future, we want everything to operate like the WEDGE. Cash, check, or charge. Everybody has insurance, but the insurance pays them, and then they pay the doctor. We'd even like WEDGE hospitals. There's really no reason we need a third party in here the way it is. So here's another way to look at the WEDGE. Oop, something happened there. Here we go. Today, the payer's at the top. The only one who knows what's happening in this little relationship here is the payer, who determines the data, the dollars, the decisions, all in here. We need to separate this and split it up: patient, doctor, patient, hospital, patient, insurer. So there need to be 3 direct pay relationships. That is the way it used to be, and so we say it's going back to the future. That's the way we believe it has to go back to, in order to become affordable, personalized, get to spend the kind of time that you need with your doctor. Lots of people won't go in because they're paying cash. They're not expecting somebody else to pay the bill, so they become very cash sensitive or cost sensitive. Okay, just a few more things about our organization. So Big Brother in the Exam Room, it came out in July 2018. It has actually won 8 awards. We only just put 4 of them up here. And I have been told by people even in the tech and data industry that it's one of the best histories ever written as to how we got to the point that we are now, where the electronic health record has been mandated. All the doctors are sharing our data. The computer is essentially controlling what happens in the exam room, and those who populate the instructions and the directions and the protocols on the computer are controlling the doctors. And so this really describes the history of it, and then has list of things to do in the back for patients, for doctors, for state legislators, and for members of Congress. And you can find it at bigbrotherintheexamroom.com or wherever books are sold, including Amazon and other places. So here is just a picture of one of the COVID-19 updates. This was number 13. Here we go. And they're Facebook Live videos. I'm doing 1 or 2 a week. It depends. And our office just came back. So we've been out for 11 weeks. but I would come back and do these, but the whole team is now back here in the office. This is number 13. You can view them all at our Facebook page. You can use this bit.ly, or you can just go to CCH Freedom. So once you get to Facebook, just put in CCH Freedom or the name of our organization, and that will bring you to the page, and just click on the videos and you can see them. They've been pretty popular. It's been fun to share information about COVID-19 and things that a lot of people aren't talking about. And, you know, like, is face masking legal? So for instance, in Minnesota, it's actually not legal to walk around with a mask, and yet Minneapolis and St. Paul have just put in mandates for masking. So, you know, this is an interesting time in our country, and we wanted to speak into it and give people information that they don't know and might not put together. So we pull it together, and then I put it into this video. And here's just information on, well, my name, but then on the organization, our website, phone number, our Twitter accounts, Facebook, and the rest. So that's really my presentation, and would be happy to take questions from viewers.
Wonderful, Twila. That was fantastic, comprehensive, and I think as some of our regulars raise their hand, just look for that raise hand icon, folks, and I'll call on you. I think they will like your comprehensive reform plan, and it is so timely, given what's happened with this hysteria, with these mandates, with the fear. And I see a couple of hands going up already. Paul Roberts, I'm going to ask you to unmute yourself and go ahead and ask your question. I know you have a documentary out on diagnosing healthcare. Tell us about that and what you thought of Twila's presentation. Ask your question.
Well, thank you.
Yeah,
can you hear me okay?
Yep.
I hear you.
Oh, okay. Yeah, great presentation. And thank you very much. With regard to the film, just briefly, we've found a lot of success so far, which is a good early sign. Just got into 3 festivals, and we just launched the festival run, and got some pretty big awards, like Best Feature Film awards and that sort of thing. So things are going well, and I hope that continues. Hopefully I'll have some periodic updates along the way, and can share that. But it kind of ties into a comment that I had that I wanted to bring up, and I'm not sure this is a question more than a comment, or how you might respond to this. But what I do with my job is medical case management. Basically it involves coordination of care. My comment would be that a lot of times I'll need to coordinate complex medical care, and I'll have to acquire someone's medical records to provide, say, to a new doctor. The new doctor that the patient is seeing doesn't have access to the records. And because of the HIPAA laws, and I know your state apparently doesn't follow HIPAA, but the HIPAA laws in Florida, it's a pretty arduous process, and the hospitals are so afraid. I think it's $30,000 is the penalty, for violating HIPAA. But they're so afraid of the charge that they make you run through 3-4 extra hoops, and you just can't coordinate care very effectively. So I'll just kind of, bounce that off you, I guess, or see if you have any comments on that.
So HIPAA really is a permissive data sharing rule. And so it says for payment, treatment, healthcare operations, no patient consent is required for this sharing of information. And all sorts of other things, as I pointed out, are also allowed without patient consent for data sharing. And so, sometimes when I hear this, I think, is this for proprietary reasons? Is it because the medical records, you say that they're afraid, but the fact of the matter is it's a permissive data sharing rule.
Yeah, and I agree with you, like what
happen.
it should be.
The fact that they say that they won't do it, you know, the fact that they say that they're scared, no, it's what it is. It's not what it should be, it's what it is.
Right, according to law. Yeah, I understand what you're saying, and I totally agree with you. I wish, believe me, in my daily life of work, I wish that was the case, and you could just cite that, you know, and move on. But that it doesn't work. The administrators at the hospitals, they shut down. I think
it's proprietary. I just think it's much more about they want to keep their data to themselves, and they don't want all the burden of sharing the records. It is a burden to find everything, and so, you know, slow walking it all. You know, I can't tell you for sure, but what my point is, the data sharing can happen without consent. That's my point.
Right.
So
yeah, and that's yeah. I mean, that's the good thing, and that's definitely what I'm trying to promote as well in the film.
Well, I don't think it's a good thing. So that's also my point. HIPAA takes away the consent rights of the patient. Those consent rights were always there before HIPAA. What HIPAA did was, as Secretary Donna Shalala said in her first recommendations to Congress, there is an age-old right to privacy, and I'm paraphrasing here, but we're going to change that and allow the sharing for publicly useful purposes. And I took away all consent rights.
I rarely get into a debate about such matters, but I think this is a kind of a sticking point with me, and not to debate you too much, but what do you, I guess what I'm trying to say, what about the notion of policy over reason? In other words, let's say that someone just had a bad car accident, and let's say that they have a head injury and you need to get a CT of the head, and you need to get that record over to coordinate care. As a medical case manager, that's what I do, right? And if they're saying no, that compromises medical care. That compromises the patient's quality of medical care. It can be a debatable issue if privacy is more important at that point in time. And I understand what you're saying, that there's, you know, bypasses, but well,
first of all,
pretty passionate about this. I do believe in patient privacy. Don't get me wrong.
So yeah, well, so first of all, this would take a longer time to figure out all the nuances here, because the fact of the matter is HIPAA and even the Minnesota law has a break the glass feature. So if it's going to endanger the patient, then you can share the data without their consent, but you have to actually.
But I wish everybody was on that same page with what you're talking about, and that's just simply not the case. They're so concerned with policy and with fear of being sanctioned that just simply does not happen. And I'm boots on the ground. I know what I'm talking about.
So yes, but there's two things here. One is that they can share the data, and you're having a hard time getting them to share the data, even though they can. That's one thing. The other thing is that they never before had a legal right to share the data until HIPAA. And now all of this data is being shared for all of these purposes without their consent. And they may be very happy for you to share it for care coordination, or they may not. And they have a right to decide whether or not you can have that information. And because it's the patient's information.
But
and the only thing I want to say here is, because I don't know if there's anybody else with hands raised, because I don't know if we're having a debate here and everybody's just like, me too, because I have no idea. But because, you know, this is probably a discussion we could have over the phone.
Okay, well, I'll let it go. No, I appreciate it. I appreciate the input and the feedback.
I mean, maybe there's time here, but I'm just saying, I don't know if there's other people.
Yeah, that's fine.
There is, but you know, a good discussion back and forth makes these interesting, because Twila, you are the leader in privacy, so some practical challenges can make that better known and understood by folks. Kathy, you're on mute. Go ahead.
Yes, I'm ready.
I'm listening.
Hello?
Go ahead, Kathy. Ask your question.
Okay, Twila, I really love everything you stand for, and one of the things I've been trying to do, and it hasn't been that easy, is to get some interest or get somebody into my area, which is Cedar City in southern Utah, about 30,000 population, to a direct primary care, somebody to set up and have some direct primary care. Is there any way I can get help to go about it? I kind of have a little bit of help before, but I didn't feel like it was very effective.
So direct primary care, which is this relationship between the patients and the doctors where the patients agree to pay a certain amount of per month, and then they get all of this roster of services. And it really does depend, that roster of services depends totally on the doctor that you choose and what they decide to offer. So some of them offer EKGs for nothing, you know, beyond your monthly payment, that sort of thing. And so it's not concierge care. Concierge care kind of acts the same, but they take insurance. Direct primary care does not take insurance. They are cash, check, or charge. And so you're asking a question about how to get one in. I think that would take a community effort to go after all the doctors and say, you know, who's interested in having one? We've got this many people who are interested in being a patient at a direct primary care. I mean, if that that's a different way to start. Usually what happens is that a doctor decides, you know, I'm done with all this third-party control of my practice. I'm done with it, with being paid a pittance by the third-party payer for all my skills, and I'm going to start this direct primary care. There are outfits, the Association of American Physicians and Surgeons, and the what is it, DFP, Doctors for Patient Care. Both of them offer training for doctors who want to become direct primary care or DPC doctors. And so there is this movement to make it happen, but for you as an individual to try to get some doctor to do it, you'd probably have to get a community or enough people or you could do a survey for all the doctors and say, who's interested in direct primary care? If we can get enough patients for it, are you interested in starting it? And that would be a real arduous grassroots campaign, I think, unless you already know of a doctor who's starting. Usually it starts from the doctor.
Okay, well, thanks for those little hints, Phil. Who knows who I might be able to drum up.
Who knows?
Twila, Charlie here. About the unique patient identifier that Ron and his son Rand Paul have done yeoman's work withholding funding for that violation of privacy. You mentioned an exemption under the Minnesota privacy law for public health, and you mentioned the databases that leak. As a health freedom activist myself, I know that the prescription database meant to target opioid abusers has been abused, it's been leaked, it's been used to deny legitimate pain patients their medicine. And then the vaccine database has been used as a threat for folks who aren't complying with the bills in Congress. And what do you think about leakable databases and whether these databases should be managed by the state, whether or public health exemptions and that kind of thing?
So there are probably some things that a state health department should do that are, you know, really serious conditions, but vaccination databases, no. Birth defect databases, no. Prescription monitoring, no. I mean, all of these things are not the place of the government in our lives, and we can see the negative ramifications. Immunization registries, I think this is interesting maybe for your listeners to understand that one of the reasons why doctors will say no to patients who refuse vaccinations and they'll tell them go find another doctor, one of the reasons is because the state, the federal, and the health plan quality measurements often deal with vaccinations, and the percent of your patient population that is vaccinated. So the pressure is on them to get everybody vaccinated so they can get their full payment. So the quality measures are really a control mechanism from outsiders to try to get what they want to have happen in the exam room to happen. And sometimes you'll find a doctor who is totally with patient choice or vaccine choice, but they're in a group of 4 or they're in the group of 10, and the other doctors come down on them because it makes the clinic scorecard look bad on vaccinations. And so these kind of registries, and as you said, the prescription monitoring registry, right? Doctors are afraid. They're now afraid to take care of their patients' pain. And so there are patients who are suffering because they can't get their pain medication that they actually need. The prescription monitoring databases, now there are some use of them by law enforcement. I mean, when they started, and I remember when they started, it was all about helping doctors to know which patients are doctor shopping and be just voluntary, and but we never believed it. So from the very get-go, we opposed the prescription monitoring database. And now we have in Nebraska, as I talk about in my book, I actually have a fairly big section about this prescription monitoring system and how it's not working like they said it was supposed to work. It's just not working. It's not stopping all of this additional medication use or illicit medication use. But the other thing is that Nebraska has decided to use their prescription monitoring system for all medications. So all prescribed medications are now ending up in this government database. Somebody should sue about that, because I mean, that's just wrong. It's a violation of the Fourth Amendment at the federal level, and most states have a Fourth Amendment like part of their state constitution, which is that there can't be any search or seizure without probable cause of paper, persons, effects, and homes. And your prescriptions are within that realm.
And excellent answer. That is a huge issue with privacy and marginalizing, legitimate opt-out patients and paying patients. How about the role of cash going to your WEDGE network? How significant have you found cash appointments to be as you've grown that network in terms of a panacea for health reform? How sold are you on cash as a significant part of health reform?
I'm totally sold, because this should be a two-person relationship. As I said with the WEDGE, it used to be that you would come to the hospital and you'd pay your hospital bill. And if you had insurance, then your insurance would pay you. Insurance didn't pick your hospital. There were no such things as networks. Networks are a way to ration care. And people don't understand that. Health plans are a way to ration care. As I said, they are the corporate version of socialized medicine. The health plans centralize the dollars, the data, and the decisions. And they can do this because they control all the money. They get it's considered prepaid healthcare. It's not, a health plan is not actually considered insurance. It's considered prepaid healthcare. So you pay this health plan, this bundle of money, in advance for them to pay all of your medical expenses, except that the government gives them the right to create networks, but also gives them the right to say what's medically necessary or not. This would be sort of like putting all your money in the bank, and then the bank would decide whether or not you would get any of it back, and they would be able to keep a certain percentage of it. And you'd have no say over it. And that is where the health plans are today. And they have this power because they have all the money. And the Affordable Care Act was considered a $1 trillion windfall for the health plans, because the Affordable Care Act has all of these redistribution systems within it, just a ton of them. And just for one example, the guy who's 50 years old who has to pay for pregnancy coverage, and he's not married and he's never going to be, and he's got to pay for all sorts of child kind of coverage, because the Affordable Care Act says every policy has to cover these 10 essential health benefits, as prescribed by the U.S. Department of Health and Human Services, which means that the health plan gets to charge you for absolutely every one of them, even though you know you're not going to use them. So you can't have a customized policy, and that means all of these things that you have to pay for that you'll never use is money in their pocket. It's just one of the things. So really the money needs to be in the pocket of the patient. They need to have a traditional indemnity policy that pays only for catastrophes, because that's what insurance is for. It's to protect you against a financial disaster. And health insurance is to protect you against a financial disaster caused by a medical disaster. So unless you have a really expensive chronic condition, or unless you have a catastrophic illness, or I always say crash, car crash, coma, cancer, right? Unless you have one of those, you shouldn't pull out your health insurance. Everything that's routine and minor should be paid for with cash. There shouldn't be any third parties involved. Third parties have all of this money that they take out of the middle between you and your doctor, you and your hospital, and you have to pay that. And the way to bring prices down to make it affordable is to go to cash, check, or charge. Have this a two-person relationship at every angle, at every part of it. You pay your bills, so you decide when to go in. You ask the prices because you're paying your bills, whether that's at the hospital, and they know then they have to give you the prices because you've got cash in hand. It's not a negotiation with a health plan. And then at the insurance company, it's the indemnity policy that pays you, and they know exactly what they're going to pay you because they figured out the prices in advance for all these things, and the hospitals know what the prices are in advance for all these things. And so they basically know what you're going to be paid by the insurance company. So this is totally the way to go. The fact that Ted Kennedy got these managed care organizations started, Nixon actually got them started, 12 pilot programs, and then Ted Kennedy got the act, and then it's just been building ever since then, the HMO Act. I talk a little bit about that in the book, but I also wrote something for the Foundation for Economic Education fee in Ideas for Liberty, I think is what it's called. And I did it back in like the year 2000. And Congressman Ron Paul got it published in the Journal of the Congressional Record. But it says blame Congress for HMOs. And it tells you the history of how we got to where we are. But the important thing is, how do we get out of where we are? And it's really about getting back to real insurance and making those health plans compete for your care. And real insurance is very affordable, very, very affordable. And cash, check, or charge payments are very affordable. Routine and minor care can come down to being very, very affordable. So it's totally the way to go.
There are some short-term plans, indemnity plans out there. The problem with the Affordable Care Act short-term plans is they're all using networks to handcuff your choices. You mentioned a couple of sharing organizations. A lot of folks are starting to see the sharing organizations as the rising competition to insurance, sort of like how credit unions have given folks an alternative to banks. You can't tell much of a difference. It's just that with credit unions, you get treated better, some better rates. People are really pleased with these sharing organizations too. Tell us about your thoughts on sharing a bit more.
So healthcare sharing has been around for a very, very long time. There's actually about 164 groups, but most of them are really tiny. Like this Chinese group there or that Mennonite group there. And what they do is they share each other's medical expenses. But there are around 4 well-known large organizations that started in the 1990s. And they too share medical expenses. And they all work differently. Some of them have escrow accounts. Samaritan Ministries has an arrangement where you pay a person. And so whoever needs your money that month is who you pay your share to. So you send it directly to their house. And that's the kind of sharing that that I prefer, actually, because you really know exactly what's happening here with your money and who it's going to and why. And so it doesn't have to be comprehensive. It can just be so-and-so had a heart attack, you know, send your share to them. And if you sign up for health sharing, that's what you're agreeing to, is that little thing. You get to tell what it is that is wrong. So whatever you want to say, whether it's really small or kind of detailed, you can say. And so you pay a certain amount. You pay a certain amount every month, and the bills are shared. So it's a cooperative. It is not health insurance. Every one of them, again, works differently. Some of them don't start covering until $1,500 that you have paid yourself. And so you might pick insurance terms, but it isn't insurance, and they make it really clear that they make no promises that they'll cover anything. However, because of the Affordable Care Act gave them an exemption to the mandate to be covered and to the penalty, health sharing organizations have skyrocketed since 2010. And back when I did a report, I think I have the most comprehensive report on these organizations. I did it in 2010. I think it was January, February of 2010 for our organization. And so it's at cchfreedom.org, including a comparison chart between 3 of them. At that time, Samaritan Ministries, for example, I remember this number, they had 18,000 families or households. And now they're in the 80s, nearing 90,000. And we're over 1 million people across this country who are doing health care sharing today. And as a matter of fact, we're going to be doing a webinar in September with one of the health care sharing organizations, just to let people know what it is, to give them an opportunity to ask questions. And I think it's a really great deal, but you really have to look at them and decide if you like their method of sharing. There is a health sharing organization that got in trouble. The important thing about this organization, which has now been sued, I think, by a state government, is that it was never an approved health sharing organization. So they never actually got approval to do it. And then it sounds like they've been keeping a lot of money for themselves. So to me, it sounds like it was a fraudulent deal from the get-go. The other ones, there's about 6, but there's really 4 that are the biggest ones. They've all gotten approval.
Wonderful. And I think, as some of our regulars know, we work with a very popular sharing company, Sedera, out of Austin, Texas, that is exploding in size. And we make cash payers and combine it with HSAs. And so we love that market. And we're down in the 20,000s, so we're where Samaritans was a while ago. And we actually were created by Dr. Tony Dale, who did the price negotiations for Samaritans. So we have a very close relationship with that company. Just a disclosure, that is our sponsor for this event. As a final question, Twila, tell us about the gravity of history right now. These lockdowns, you know, the German Interior Ministry just leaked a report that, you know, the science really wasn't there for lots of the hysteria and overreaction. And, you know, there are some pharmaceutical companies that are licking their chops at the billions in profit awaiting them if they can get some patented treatments and vaccines out there. There's app-based tracing facing us with congressional bills or governments, state government requirements. How important is your organization, especially now with consumer empowerment, as more powerful health players seem to be using the hysteria to get more controls at our expense?
Well, I think, you know, getting facts out into the mix is a really good thing. And so what we try to do is find the experts who are perhaps saying something different than the government is saying, or the media is saying, or the purveyors of, you know, those who want the billions and billions of dollars, trillions of dollars that the federal government has now taken from taxpayers for the COVID-19 crisis. And so, you know, one of the things that we like to do is just talk about things like the vaccine, or, you know, I can't remember who it was who said, you know, we need the vaccine before we quit the lockdown. And, well, no, I do remember. What am I saying? It was Minnesota's governor. And before they would lift the lockdown. And it's like, do you understand what you're saying? Because most experts will say that it's 12 to 24 months if they can get a vaccine. And Dr. Tony Fauci himself says that they don't know whether a vaccine will even be effective. There's no guarantee that it will work, and there's no guarantee that it will be effective, like seasonal flu, which one year was down to only 19% effective. And then worst of all, as Dr. Fauci talked about, is that the vaccine could backfire, so that those who take it, the virus could be more virulent if they get the virus. You know, it's bringing out facts like this, or contact tracing. What are your rights? What are your rights for contact tracing? And what's your plan? What's your plan when somebody comes to your door, calls you on the phone, enters your hospital room? What's your plan? Do you want to tell them all your contacts? Do you know what will happen to your contacts? Do you know whether or not the force of law is going to come down? What if you never infected your contacts, but they bring the force of the law down on them? So, you know, there are just lots of things to think about. I suggest going to a place called Unheard, and that herd is HERD, as in don't follow the herd. So Unheard. And there's some great videos with epidemiologists and Nobel laureates who say something very different than is being said in the media today. Really talking about, you know, from really a statistical point of view, you know, what they're seeing, about how this isn't as serious as people say it is, and how the lockdown is really going to be worse. The ramifications of the lockdown are going to be worse than what happens from the disease. And so, you know, I think our videos provide that resource. I really went into the pathophysiology, which has been really a mystery. I mean, to understand that COVID-19 is less of a lung disease than it is a vascular disease. And so I actually do drawings and bring those drawings for people to take a look at, so that they can understand what COVID-19 really is as the doctors figure it out. I bring good news, I bring interesting news, facts, and hopefully helpful tips of how to deal with this and to make decisions about, like, wearing masks, for instance. Is it legal? Is it science? You know, bringing all that stuff to bear.
Fantastic. Well, as we close here, Twila, it's been really fantastic to have you give us your update on some of the biggest issues in healthcare. And I think privacy certainly is underappreciated as a grave threat to individuals and families and businesses. And you've always been the leader there. And so many of these other issues that people don't really know much about, like the DNA capture of your babies, and you know, just the current scariness of the hysteria. So how can folks reach you again? And we'll say goodbye.
Sure, they can go to cchfreedom.org, cchfreedom.org. They can find the videos there. They can find the patient toolbox. They can find all of our information there, our contact information. They can find us on Facebook, on Twitter, my handle, and the CCH Freedom handle, as well as on Facebook.
Wonderful. Thanks again, Twila. And folks, come on back next week. We'll have special guests each week that show the benefits of the cash patient market that Forbes featured us for creating. And we want to highlight all the leaders in health freedom and disruption that are giving us a better health market that we can be proud of. Twila, thanks again. Have a good night.
Thanks so much, Charles.